Shavina Frank. I'm one of the ENT registrars at the University of Cape Town. And today I'm going to be talking about the HINT exam in acute vestibular syndrome and how we can better understand what it's about and when to use it. These are my disclosures. I recently had a patient. This is actually quite a new patient that I saw over the weekend. He was a 50-year-old gentleman. He's actually a German tourist on holiday, and he is a known hypertensive with dyslipidemia. And he presented with the first episode of sudden onset. In his words, in his native language, he described it as a gevoede swakens. I hope I'm saying that right. But essentially, his wife later came to tell me that it means he was swaying. So he had a sense of swaying. He denied any spinning movement, and it was continuous, and it did worsen with changing position. It didn't matter whether he sat up, lie down, try to get up. The dizziness that he was experiencing was continuous. He did have quite an unsteady gait, and he had quite a lot of nausea and had 2 vomits. He had no recent change in medications or new medications being added. He had no preceding acute illnesses and no other recreational drug use. The non-smoker, non-drinker. And he also denied any oral symptoms. So on his examination in casualty, he had pretty much normal vitals. His blood pressure was slightly elevated at 169/64, but otherwise the rest of his vitals were normal. He was GCS 15 out of 15. He never lost consciousness. And it was noted that during my examination, he was falling to the right side when walking, and it was consistent. There was no other focal neurology noted. He had a normal, otherwise cerebellar examination, no other cranial nerve fallout. I proceeded to do a HINT exam on him. He had a negative test of Skew. He had direction changing Nystagmus in the 4 quadrants that I tested. And he had no corrective saccades on a clinical head impulse test. Unfortunately, fortunate for him, his international medical insurance kicked in and he was transferred to private with a private neurologist. He had a MRI scan done at the private facility. I apologize for the image that I borrowed from the internet. Unfortunately, I couldn't download it in time for this talk, as I didn't have access to the private images. But essentially, what this illustrates is this is an axial T2 flare image, and as you can see, there is a bilateral hyperdense lesion in the dorsal aspect of the medulla. That's essentially what his scan showed. Subsequent to that, he was admitted into the hospital. He received high-dose steroids, and about 48 hours later, he felt much better, enough to actually self-discharge, and went back to Germany. On chatting with the neurologist, he later told me that the patient did actually receive plasma exchange in Germany when he arrived, and he was still awaiting on specific serology testing for anti-MOG IgG disease to help distinguish between neuromyelitis optica and multiple sclerosis. So this was the differential that he had. So he had a central lesion, despite vertigo and nausea and vomiting being the only symptoms. So what is the definition? So in layman's terms, it's a perception of movement, whether it's rotational or not, when no movement exists. So the Bharani Society published a consensus document in 2006, where they tried to better define what vertigo is. And so they subdivided it into 2 big sections, that being internal vertigo, or as to be more simplistic, just vertigo, and external vertigo, which is where there is a vestibular visual symptom associated with the sense of motion. So the definition is that internal vertigo is the sensation of self-motion when no self-motion is occurring, or it's the sensation of distorted self-motion during an otherwise normal head movement. This is to be distinguished from external visual sense of motion, which is referred to in the classification as either external vertigo or oscillopsia. And then oscillopsia is further divided into false spinning sensation vertigo or non-spinning vertigo. And in the non-spinning vertigo, it can be further delineated into swaying, tilting, bobbing, bouncing, or sliding. So that's the new definition. Acute vestibular syndrome was first brought out by Hodgson and Barlow in 1998. And essentially, this was one of the first definitions that came out. And essentially, it defines acute vestibular syndrome as a rapid unilateral injury to either peripheral or central vestibular structure, which produces an acute vestibular syndrome, which consists of severe vertigo, nausea and vomiting, spontaneous nystagmus, and postural instability. The Bharani Society adopted this, but then also added that they included that it was continuous vertigo that lasted for more than 24 hours, and then also associated with nausea, vomiting, and head motion intolerance. So that was the bit of the change from the previous definition. Then our colleagues in the EC, they also came out with a consensus guideline. This is the GRACE 3 guideline, which is the latest one. And simply this was to try and better define what acute vestibular syndrome is. And their definition, and it's associated with the graph at the bottom, where the y-axis is symptoms and the x-axis is time. Acute vestibular syndrome, also known as AVS, is a clinical syndrome of acute onset of acute dizziness lasting days to weeks, and generally includes features suggested of new ongoing vestibular system dysfunction. And then they give examples of this, that being nausea and vomiting, nystagmus, and postural instability. So they also included the fact that it was continuous dizziness with associated nystagmus. It's also important to note that they also further defined it that it lasts for about 7 days with an acute peak period, which gradually settles over a week if there is complete spontaneous recovery. So that's the GRACE definition of it. So acute vestibular syndrome has an estimated annual incidence of about 3.5 per 100,000 in the population. It's also estimated that about 10 to 20% of dizzy patients visiting the EC actually have acute vestibular syndrome. So if you correspond that into numbers, which they did in the US about 5 years ago, it actually works out from between 25,000 to 500,000 annual visits to the EC within the US every year. With an acute vestibular syndrome. So it's quite a lot of patients that's coming with this. And the most common cause for acute vestibular syndrome is vestibular neuritis or labyrinthitis, which the Bharani Society have actually classified together, and they've classified it now as an acute peripheral vestibulopathy. So that's the new phrase instead of vestibular neuritis or labyrinthitis. And then the second most common cause of AVS is an ischemic stroke, which can either involve the cerebellum or the brainstem, and that accounts for about 5 to 10% of all patients that present with AVS. And because these symptoms and signs overlap, there's two problems. One, there's a lot of misdiagnosis, and there's also quite a lot of overuse of neuroimaging, which can be quite expensive. So this slide is to state the obvious. Before you do a hint exam, you need to rule out a central cause. And these are some of the things that you need to look for before you think about using a hint exam. The hint exam should never be used as a primary examination tool for these patients. It's primarily used for patients who don't have obvious central features, but do present with with vertigo and the associated nausea and vomiting and oscillopsia. So in those patients that have no obvious central features, those are the patients that you would do a hint exam on. So specifically, things that you need to exclude are focal weakness and paresthesia. You need to look for the 5 danger Ds, that being diplopia, dysarthria, dysphonia, and dysphagia. You need to check for vertical nystagmus at rest. You need to ensure that the patient is able to walk unaided, or if not, assess the gait. And then also importantly in the history is to identify if there's a new significant onset of headache or neck pain. On the right-hand side, I just put a diagram in from one of the articles I looked at. Apologies for not putting in the reference. And essentially, this looks at some of the more common things that you would find in central features, depending on where in the tract the lesion is. So if you look at if it's in the pons, you would also expect a patient to have hemiparesis, facial weakness, as well as a gaze palsy. And then in the thalamus, you would worry about hemisensory deficits and patient's cognitive ability. So depending on where the lesion is, that's where you would try and identify central features. And so once you've ruled that out, you'll have a list of differentials, and essentially you need to try and distinguish, is it peripheral or is it central? And that's where the hint exam helps you. The other thing that also helps you is that the history, and by definition of acute vestibular syndrome, it's a continuous vertigo. It's not episodic. And so then you can really rule out things like BPPV from your differential diagnosis. So what is the hint exam? So this is the original hint exam, and then I will talk about the hint plus exam a little bit later. Essentially, it's got 3 components. It's a head impulse test, which tests the vestibular ocular reflex. You need to look for nystagmus, and primarily nystagmus in the horizontal gaze, so right and left. And then also you need to look for a alternate cover test or a test of skew deviation. So those are the 3 components. So why is it important? Well, the reason is because since healthcare has become more expensive and ECs have become more busy, there's not always a lot of time and money to try and triage these patients, especially as an ENT coming into a casualty and you're not sure if the patient has a peripheral or central lesion. So there were quite a few studies that have come out over the years since the introduction of the hint exam. And they particularly looked at the hint exam up against various other diagnostic procedures, that being MRI scan, CT scan, as well as other clinical examinations. So this was quite a big meta-analysis that was done quite recently. It was just and it was updated in April 2023. And essentially, this was an assessment of the accuracy of bedside findings to differentiate between peripheral and vestibular neurological causes. This meta-analysis identified over 6,000 citations, but in the end, only really looked at 14 articles that met their inclusion criteria, which was quite strict. And of these 14, 10 were actually study cohorts comparing different imaging modalities to specific bedside tests, those being the hint exam, the hint plus exam, and gait and truncal instability. And so they came out with a few results and conclusions. First of all, they said that head CT scans should play a very limited role in the assessment of these patients with acute vestibular syndrome. And that's these scans in some of the studies had quite a low sensitivity of approximately 16% on average for acute infarction. And then in another study in this meta-analysis, it also further showed that the sensitivity was even lower than a simple assessment of gait and truncal instability, where they weighted up against patients that presented with grade 3, which is instability on upright posture. And this even showed a higher sensitivity than CT scan, so it's not recommended. It also noted that brain MRI is not always readily available in most hospitals, and that if it is, the quality and the sensitivity of these MRIs within the first 24, 48 hours was not great. It showed a false negativity rate of about 15% in patients who ended up having strokes. And so the average sensitivity of the MRI, which was a diffuse weighted image MRI, was about 85%. In comparison, if they looked at the HINTS exam up against the MRI diffuse weighted imaging, and this is specifically within the first 24 and 48 hours. This is not, 5 to 10 days later post onset of imaging. And this basically showed that the HINTS exam had quite a high sensitivity on average of about 95% and a specificity of 92%. That's compared to the diffuse weighted imaging MRI of only 85% sensitivity. And the other important thing that they also noted is that people that were sort of schooled in the HINTS exam and knew how to do it and use it appropriately, there wasn't actually a change in the sensitivity rates between examiner type. In other words, if you looked at subspecialists, that being neurologists, neuro-otologists, and general ENTs, they got about on an average of 94% sensitivity with the HINTS exam. And then non-subspecialists, those are essentially the EC docs and the GPs that see these patients, and their sensitivity was 95%. And I think it's probably because they do it quite a lot more because they're in an EC, so their population volume is higher. And so subsequently, their recommendation is really that one, bedside predictors are essential in identifying these patients and triaging them as to whether they need an MRI scan or not. And another thing that they also noted was the need for an additional test, specifically the HINTS Plus test, where they add audiology assessment to help rule out anterior inferior cerebellar artery infarcts, as these patients often have associated hearing loss. So that was the recommendation from this study. And it was another study done in 2014, and it was published in the Journal of Neurology. This study looked at about 105 patients in one institute over about 13 years. All of these patients presented with an acute vestibular syndrome. In other words, they met the definition where they had days to weeks of continuous vertigo, nausea and vomiting, head motion intolerance, gait unsteadiness, and nystagmus. In this study, they showed that early MRI, once again within 48 hours of symptoms, was 47% sensitive for detecting acute infarcts of less than 10 millimeters, most of them involving the inferior cerebellar peduncle and the lateral medulla. However, they did much better in patients who had infarcts of more than 10 millimeters, and their sensitivity rate was about 92%. So their recommendation in this study was that a detailed bedside exam, including a HINTS exam, was important in each of these patients because it showed a more than 99 sensitivity for diagnosing infarcts, and specifically infarcts of all sizes. So there was no real difference in using the HINTS exam. And they also just noted that there was one false negative for them. That's why it's more than 100. And then the last study as to why the HINTS exam is become so relevant these days. Sorry, I'm just going to see if I can just mute everybody. Just trying to find it. Apologies. Everybody can just mute themselves on the panel. We'd appreciate it. So looking at this article, it was done at Johns Hopkins University in Baltimore. And the data that they got for this publication was actually derived from an ongoing stroke study that they were doing in patients with acute vestibular syndrome over about 9 years. This study was a prospective cross-sectional study of patients that presented with AVS, specifically focusing on those patients that are high risk for stroke. And then they looked at MRI specifically, and then screening patients with HINTS exam. So initial MRIs were falsely negative in about 12% of these patients. And as a result, the recommendation is that it should not be used within the first 48 hours, if you compare costs with a screening test of a HINTS exam. And then the other recommendation that they had is that the HINTS exam appeared to be more sensitive than MRI in detecting acute stroke in the first 24 to 48 hours after symptom onset. So these are just 3 of many studies that have come out over the last 10 years that have shown that the HINTS exam, if done correctly with the right patient, is superior to an MRI scan within the first 24 to 48 hours. So when do we need to do a HINTS exam? First thing is, it should not be applied in patients unless they have both significant, constant vertigo and spontaneous nystagmus. This is important because you can get a patient who has episodic vertigo, such as in BPPV, that has a negative head impulse test, but can have a positive nystagmus test. And in patients with posterior canal BPPV, they can also get a very slight positive test of Skew. And so a lot of these patients end up getting an MRI scan instead of a canal repositioning maneuver. So it's important that it's only really patients who have constant vertigo with spontaneous nystagmus in the acute setting that have no other obvious central features of a posterior stroke. So what they also recommend is that it can also be used in patients and still has quite a high sensitivity of patients that are less than 60, and in patients, elderly patients up to 92 years old. This is important because the neurologists often use a stroke screening tool known as the ABCD squared risk score. But this score has its limitations as it's inaccurate in patients less than 60 and in patients older than 92 years old. And so the HINTS exam can be used in this instance with these patients. So how do we do the 3 tests? Just briefly, there's no special equipment really needed for a head impulse test, unless you've got video nystagmography. Otherwise, if not, you can do this at the bedside. So essentially, you're going to hold onto the patient's head. The patient's going to fixate on the examiner's nose or into the camera, if you've got a camera. And the key thing here is the patient mustn't have any cervical vertebral instability, and they shouldn't have any whiplash, and they actually need to have quite relaxed posture and muscles in order for you to do this test accurately without hurting them. And essentially, the movement is a side-to-side horizontal movement, about 20 degrees on either side of the midline, followed by brisk, unpredictable movements to the center. And essentially what you're looking for is a catch-up saccades. So if you look on the diagram, which I borrowed from Dr. Johns, who is he is actually a EC consultant with a particular interest in vestibular syndromes. And he essentially says that a normal head impulse test is when the patient's eye remains fixed on the target, when the head is turned rapidly to a specific side, but the eyes stay on target, either that being in the camera or in the nose. An abnormal head impulse test is when, so if the examiner is moving the patient's head, the eyes rapidly, so it says that the patient's head is turned by the examiner rapidly towards the patient's right side, and then the eyes overshoot, and then there is a quick catch-up saccades with the eyes moving back to the target. This is a very reassuring sign for most EC doctors and ENTs, because this tells us that it could potentially, most likely, be a peripheral cause. Importantly, with the rapidly advancing technology that we have, video nystagmography has become quite a useful tool in doing the head impulse test, specifically because you can actually test the gain values for all 6 semicircular canals with a video nystagmography. It can also record both overt and covert saccades, and it can also record the number of corrective saccades seen in the patient and their latencies, which is quite useful because those cut-off criteria can actually assist in us diagnosing the patient and the side of the peripheral lesion. Whereas if you do it just with the eye, often it's missed and these patients get sort of an equivocal clinical response, which can't really be detected by the clinician. So it's quite useful in that. It's importantly to note that the head impulse test it's a permanent feature of unilateral vestibular loss. So when you have an insult to one of your vestibular systems, and there's not spontaneous complete recovery, there's always a head impulse test positive result in these patients. Just to mention that although an abnormal head impulse test is a typical peripheral sign, it can be due to a lesion involving a central horizontal semicircular canal afferent. It can also be as a result of the medial vestibular nucleus or the root entry of the cranial nerve, or even at the cerebellar folliculus, that can result in ischemia. And so this test needs to be in conjunction with all other 3 tests, including a hearing test in the HINTS Plus exam, in order for you to properly use what the test means. So that always needs to be bearing in mind. So that's just a small little side note about these patients. Okay, then looking at nystagmus. So the clinical exam of these patients should always start by analyzing the direction of the nystagmus in all cardinal positions of gaze, and then followed by testing the effect of fixation block in each gaze position. And so you can get different types of nystagmus. You can get gaze-induced, you can get direction changing, you can get head-shaped nystagmus, or you can get a pure torsional or vertical nystagmus in these patients, which increases their risk of a potential stroke. And then it's important to note, once again, that visual fixation suppresses nystagmus, which is of peripheral origin, but it does not suppress nystagmus that has central origin. So that's the important thing about the visual fixation suppression. So the primary position of the spontaneous horizontal nystagmus that increases with fixation removal and kind of follows the Alexander's law is essentially the rubric for peripheral vestibulopathies. And this is the definition accepted by the Barani Society. So if you look at the diagram in panel A, this follows findings typical of a peripheral nystagmus, which remains in the same direction when the direction of the gaze changes. Whereas in a central nystagmus, the gaze changes when the direction changes. And then removal of the visual fixation increases the intensity of the peripheral nystagmus, but not of the central nystagmus. So that's what the panel A, which is essentially the panel on the left-hand side, shows. The image and panel on the right-hand side illustrates how removal of fixation helps to differentiate between a peripheral and a central nystagmus, where the nystagmus is predominant in one direction of gaze during fixation. And then with removal of the fixation, peripheral nystagmus may increase in intensity and become more apparent. So that's shown in the double arrows that you see on the top right-hand diagram. Whereas if it is central nystagmus, the intensity of the nystagmus doesn't change with fixation removal. So that's how you use the nystagmus in the HINTS exam. Importantly, I've just put a note there that once again, you can also use nystagmography, which gives additional qualitative parameters to the nystagmus. You can actually just slow it down if you miss it, especially if patients have continuous fixation and you don't have something like a Frenzel lens to try and prevent fixation. And just another side note that the clinician should also be aware that vestibular migraine can present with acute prolonged vertigo with central or peripheral patterns of nystagmus during the acute sort of episode or throes of the attack. And that ictal eye movements recording during a vestibular migraine episode may reveal spontaneous upbeating or downbeating or torsional, and they can also have a gaze-evoked nystagmus in addition to a positional nystagmus. And so the side note here is that unless the patient meets the criteria for the diagnosis of vestibular migraine and has had a history of multiple prior attacks, you cannot rule out a central cause. And so you always need to do an image on these patients, especially if it's the first time where you've done a HINTS exam and it's shown to be a central HINTS exam finding. In that instance, an MRI scan would be indicated. The test of Skew or test deviation is a vertical ocular misalignment, and it is a sign of abnormal otolith ocular reflex. And it can be seen in both peripheral and central causes of acute vestibular syndrome, as the lesion can actually occur anywhere along the otolithic pathway. And often it leads to two signs that you can see. You can see an ocular tilt reaction, which includes a head tilt, and then also an ocular counterroll and skew abnormality. So a typical central lesions that produce these sort of pathological ocular tilt reactions occur on various pathways of the otolytic pathway. So specifically in the vestibular nuclei, typical the lateral medullary and the Wallenberg syndrome often presents with these ocular tilt reactions. If there is a stroke within the medial longitudinal vesiculus, usually within the pontine area, that can also cause a positive test of skew. And then also if the lesion is in the midbrain, specifically in the interstitial nucleus of Cardinal, they can also get a positive test of skew. And so in order to be able to address this potential localization dilemma, patients that do have an acute vestibular syndrome with a large skew deviation often favors a central cause rather than a peripheral cause. And then also, as I mentioned, patients who have BPPV, specifically posterior canal BPPV, that have episodic vertigo, can also have a slight positive test of skew. So the difference here is that this is a large deviation in the test of skew, and if you combine it with an ocular tilt reaction test, it's quite sensitive for central lesions. And so often this test has to kind of be interpreted with other ocular reflexes in order to kind of pinpoint the localization. So how do we do it? It's essentially you're alternating covering of each eye. And so the examiner covers one eye and then moves the cover over to the opposite eye. And when they do this, they observe if there's any vertical movement of the uncovered eye. And if there is, that's a positive test of skew. The nice thing about if you have a video nystagmography, you can actually measure the deviation amplitude that can tell you if it's a large or a small, specifically in patients where you're not 100% sure if it's episodic or if it's a continuous vertigo, especially in patients with triple PD, where you're not exactly sure about the duration and the episodic nature of the vertigo. So looking at the HINTS Plus exam, this is not a recent, but a relatively recent addition to the HINTS exam. And it's essentially a bedside test for hearing. So if you're in a busy ED or in your peripheral hospital as an ENT and you don't have an audiologist available on hand to do a formal audiogram, there's about 3 crude tests that they mention in the literature. The one is essentially standing, depending on which ear you're testing, and basically doing a finger rub next to the patient's ear and seeing if the patient can hear the rubbing. Very crude test, but sometimes that's all you have. If you do have a tuning fork available, tuning fork tests, Renee and Awiba can be done as well. And then also, if you can do a whisper test is also useful in helping you distinguish peripheral versus central. Although a formal audiogram is obviously the gold standard. And really here, it's because anterior inferior cerebellar territory strokes are quite often difficult to diagnose because they pretty much have the same lesion and the same symptoms as a peripheral lesion. But they often have an abnormal head impulse test because it involves the labyrinthine and the cochlear nucleus, and sometimes it can even involve both of them. And so the patients that have an ICA stroke, as they call it, they often have sensorineural hearing loss. So that's the added addition to the HINTS exam. And then just specifically looking at another interesting test that's been added. It's not officially added to the HINTS Plus exam, but it's something that is being looked at more and more in the literature because it's quite an easy test to do as part of your neurological examination. And that's looking for patients with quite obvious truncal ataxia, as in with our patient that I presented earlier in the talk. So this was probably one of the first studies, bigger studies that was statistically significant. And this was a study done by Carmona and colleagues in 1996. And essentially they studied a group of about 114 patients who were admitted to their hospital with acute vestibular syndrome, where 72% of them, so the majority of them, had vestibular neuritis. And they looked at, in their population group, when they applied the HINTS examination to their sample, if it was consistent with what the literature was coming up with. So that was the first objective. And what they found is that when they did introduce the HINTS examination, they got 100% sensitivity and a 94.4% specificity to the HINTS examination when trying to distinguish peripheral from central. And so then they also then added the addition of truncal ataxia. And so how they defined it as truncal ataxia, they looked at grade 1 to 3, 1 being mild to moderate imbalance, where the patient is walking independently, but feeling a bit off balance. A grade 2 being severe imbalance with standing, but they can walk, but not without support. And then grade 3 being falling at in the upright posture. In other words, they've got complete truncal instability. And so what they found is if they used, if they looked at patients with grade 2 to 3 ataxia, when detecting either a anterior inferior or a posterior inferior cerebellar territory stroke, their sensitivity just with the ataxia alone was about 92% sensitivity, but the specificity wasn't great at 61%. And so then they added the HINTS examination, and the sensitivity kind of remained equivocal, so pretty much the same, but the specificity did go up to about 94% as well. So that did improve the specificity of their testing. And what they've also noted is in patients with that they did a HINTS plus exam with, and did this truncal ataxia, specifically patients with an acute inferior cerebellar territory infarct, they got 100% sensitivity in their specific sample. So their recommendation, because all the results were statistically significant, was that severe truncal ataxia, that being grade 2 to 3, definitely added sensitivity to the HINTS plus exam to a value of about essentially 100% sensitive. And that their recommendation was that plus examination, you should at least test if not to do a thorough neurological evaluation on top of it. So that's something that's been looked at more and more. So in summary, essentially what you want to be able to do is determine if it's peripheral, because that is a patient that does not need an urgent MRI. So in the head impulse, you want the head impulse test to be abnormal, which is reassuring. It is a peripheral cause. So in other words, you would see a corrective saccade. In nystagmus, you want the nystagmus to be fast beating only in one direction, which will tell us that that is also a peripheral cause of the vertigo. Because a vertigo that is position changing is not good news. It's essentially central. And then the test of skew, you want a perfectly vertical alignment of the eyes when doing this test to ensure that it is not a central cause. So if we're looking at it to how to divide it, so for central lesions, you have to have any of these. You need to have bidirectional nystagmus, an abnormal test of skew, and a normal head impulse test. And then sometimes you can get a positive head impulse test, but that's in a very, very small amount of patients, but the majority have this. And then for peripheral lesions, you have to have a unilateral nystagmus, no vertical skew, and an abnormal head impulse test. That's how you distinguish it with the pulse test. Okay. And then I want to just leave you with this one last algorithm, which I thought was quite a nice algorithm, kind of summarizing what we've spoken about. And this actually comes from Tintinelli, which is actually the reference book for emergency medicine specialists. And they summarized it quite nicely, because specifically what we're going to be looking at is the right-hand side, which is ongoing continuous vertigo, worsened by head movement, spontaneous, gaze-evoked nystagmus. And so following this algorithm, the HINTS plus exam is tested. And then they also mention here that the Dix Hallpike is not indicated with these types of patients in the acute setting. And then specifically what is important here, and just to highlight again, is that you need to first rule out that there is not an obvious central cause and that there aren't obvious neurological symptoms. So you would first check these, the danger Ds, focal weakness, paresthesia, all of those, before thinking of doing a HINTS exam. So those on a HIMSS exam is not for those patients. It's for patients who don't actually have other central causes besides the dizziness and the nausea and the vomiting. And those are my references. Are there any questions or comments from the panel?
No, thanks, Shavina. That's a very nice, comprehensive talk. It's the best one I've seen on events, commonly talk. I think it's very practical and appropriate to obviously where resources are limited. I don't know who's on the chat. Is there anyone who else wants to comment? So I presume if your hints points towards a central cause and you have the resource, you should probably still MRI because then you can, regardless of the timing, because you can intervene early.
Correct.
If your MRI is negative, you might still want to repeat it. You can't completely exclude it.
So in other words, those patients would need admission.
For neurology.
Yeah.
And there's no change in sensitivity between kind of the hemorrhagic and the ischemic stroke.
No, although they do say in a hemorrhagic stroke, especially past about 48 hours, they would then essentially do a CT scan rather than an MRI. So that's really the only difference between those two. But otherwise, the sensitivities within the first 48 hours, they miss about 15% of strokes. Are there any other comments? Okay. Anybody else have any questions or comments? Right. Thank you, everybody, for attending this meeting. If there's nothing else from the gallery, then we will end the meeting. I hope everybody has a good weekend.